Assalamu alaikum wa rahmatullahi wa barakatuh. Coming back to the last session of Best of EULAR webinar. Sorry for delay because of some technical issue. And this is usual, this is the problem of the webinar. Just because we don't want a delay, the last session will be very excited. It's about vasculitis. Our chairperson for the last session is Dr. Ramez Swelem. Maybe all of you know Dr. Ramez Swelem. He's a senior consultant rheumatologist, and he is actually the founder of Saudi Society for Rheumatology, and he is the former president of the first session of Saudi Society for Rheumatology. He's an excellent teacher. He's a brother and friend for all of us. And he's the first one to have a lupus clinic here in Saudi Arabia. And he established the rheumatology section at Prince Sultan Military City. There is a lot of things to say about Dr. Ramez, but because of the time, I will give him the microphone to start the session. Welcome, Dr. Ramez.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Hanan. Ladies and gentlemen, dear colleague, I'm glad to have you back for the last session of tonight. I hope you will find it fruitful and beneficial. As you know, vasculitis has gained a lot of attention in the last few years. And at last, وأخيراً, we started to move towards more targeted therapy. Steroid and cyclophosphamide may be not the only option we have in the future. In this EULAR meeting, more than 400 abstracts discussing different aspects of vasculitis. Our dear speakers tonight, they selected the most important ones to present to you. So without any delay, I will start with the first presenter, Dr. Mufaddal Al-Aitham. Dr. Mufaddal, he is a consultant rheumatologist at Prince Sultan Military Medical City in Riyadh. He is a member of Residency Training Program Committee and Quality Improvement Committee in Prince Sultan Military Medical City in Riyadh. He's board certified at the Saudi Fellowship in Rheumatology since 2018. He has great interest in being updated in the field of rheumatology and autoimmunity. And he will talk about large and medium vessel vasculitis and Behçet disease. So, Dr. Mufaddal.
Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. Thank you very much, Mr. Chairman. I would like to thank the Saudi Society of Rheumatology and all the organizers for bringing such a great event all together. This has been a great effort so far, and it's been very interesting. So thank you very much. So I will talk to you about large and medium vessel vasculitis and Behçet's disease, and I'm going to reproduce and rehearse what was presented in this year's EULAR in a concise fashion. So I'll start first with this poster about the efficacy of apremilast for the pain of oral ulcers in patients with Behçet's disease. So this is an RCT that included adult patients with Behçet's disease who had more than 3 oral ulcers in a year, and they had to have 2 or more active ulcers at the time of the screening. So they had to have also prior treatment, including systemic but non-biologic therapies, and no major organ involvement for a year prior to randomization. So they've randomized 207 patients to enter the trial with 1-to-1 randomization between active treatment with apremilast 30 milligrams BID and placebo. So the primary endpoint was an interesting thing. It's the area under the curve by week 18 for oral ulcers, and after that the placebo was switched to active treatment. So we look at the results. Basically what they've done is they looked at all the oral ulcers that happened within a 12-week period, and that made for an area under the curve. So more ulcers, higher the area under the curve, and therefore less efficacy. So if you see, apremilast started to separate from the placebo group by first, second week, and then it kept greatly separated from the placebo throughout the 12 weeks, and therefore it reached a significant difference compared to placebo in reduction of total number of oral ulcers over the whole 3-month period. Now, if you look at the pain scores, patients on apremilast again had significant reduction in the pain scores of oral ulcers over the whole 12-week period, and this was starting to separate from placebo group by the second week and continued to do so very nicely. So in conclusion, apremilast was an effective therapy for reduction of oral ulcers and alleviation of pain of oral ulcers in Behçet's disease, and more patients achieved pain control with apremilast compared to placebo, and therefore it's a useful option for patients with Behçet's who were still having active ulcers despite treatment with a non-biologic agent. Second interesting was optimization of tocilizumab therapy in giant cell arteritis, and this was an interesting study that was done to assess the efficacy and safety of optimizing tocilizumab in patients with GCA. And what they've done is that it's a multi-center study of 134 patients, and after achieving a remission with tocilizumab, they've separated the patients based on their treating physician's opinion whether to optimize their tocilizumab treatment or to continue on regular dosing. So in the optimized group, they had 43 patients, and they compared them to 91 patients in the non-optimized group. Both gender and mean age were comparable between the two groups, and the time from diagnosis or the duration of the disease was slightly shorter in the non-optimized group. So if you look at the lab data that were they were comparable in regards to their ESR, CRP, and hemoglobin levels. So around 70% of the patients in the optimized group received intravenous versus around 30 received subcutaneous, and in the non-optimized group it was around 80-20 percentage. So in the non-optimized group, over 60% received tocilizumab as monotherapy compared to slightly less in the non-optimized group. The rest of the patients received tocilizumab combination therapy. Now, optimization was done after achieving remission, so they had to be in remission for at least 6 months, and after 12 months from having that, they would start to optimize the patients. So optimization was done by either spacing the subcutaneous at 10 days or 2 weeks, or reducing the dose, or spacing the doses as less frequent in the intravenous dosing. So looking at the symptoms at the baseline, they were comparable in the optimized versus the non-optimized group. Now, after optimization, we see the normalization of inflammatory markers was comparable between the two groups, and the clinical improvement of symptoms was also comparable in the two groups. The relapse rate was not significant between in the optimized versus the non-optimized group, and the steroid sparing effect was reached equivocally in the two groups. The adverse events were both comparable between the two groups, but where things turned interesting was significant reduction in the cost of treatment in the tocilizumab optimized group. So in conclusion, tocilizumab optimization was safe and effective in GCA, and steroid sparing effect was still achieved after optimization, and this was an interesting and useful method to reduce the cost of treatment in patients with GCA that were on tocilizumab. Next was an interesting poster about the outcome on prognosis of factors of isolated aortitis, and they've looked at patients with isolated non-infectious aortitis, determining the outcome and complications in this group of patients. So this was a retrospective multi-center study that was done between 2000 and 2006, and they've identified over 350 patients with aortitis. Out of them was 136 were diagnosed with GCA, around 100 with Takayasu, 73 were diagnosed with isolated aortitis, and 48% had other diagnoses like, for example, Behçet's disease or relapsing polychondritis, and so on. So they've looked at vascular events rates, which included the formation of vascular aneurysms, or the development of dissections, or the need for revascularizations, or death. And the results at 5 and 10 years was for a cumulative rate of vascular complications was around 48 and 71% respectively for isolated aortitis, and it was significantly higher than that seen in GCA, which was 20 and 45%, as well as Takayasu, which was 19 and 35% respectively. So therefore, male gender and isolated aortitis were associated with a significantly heightened risk or higher risk for complications or vascular complications. Now, the need for revascularization was very high in patients with isolated aortitis, and it was significantly higher than those with other diagnoses. So, in conclusion, vascular complications that happened in over half of the patients with isolated aortitis within a 10-year period, and the incidence of vascular complications was almost 3 times higher in isolated aortitis compared to GCA and Takayasu, and male gender was a risk factor for increased risk of vascular complications. Next, it's an interesting poster about the role of temporal artery biopsies in patients with GCA that had negative or inconclusive ultrasound. And this was a publication from a center in the UK where they had a fast-track pathway to facilitate and accelerate the diagnosis of GCA. And their pathway was reliant on ultrasound as a modality of diagnosis. And they set standards for having a biopsy in GCA with a minimal size requirement of 10 millimeters, and it had to be done by a trained or experienced surgeon. However, they noted that negative results were quite non-reassuring at times because of the nature of skip lesions, as you know, and sometimes inadequate sampling that can give you false negative results. So the primary objective of this study was to study the utility of biopsy in patients who had negative or inconclusive ultrasounds, and the secondary objectives were to study the effects of the size of the biopsy and the effects of duration of steroids therapy before the biopsy. So the method was a prospective study, was done between 2014 till 2019, and they've divided biopsies to either less than 15 millimeters versus 15 millimeters and more, and duration of steroids was divided to less than 10 days, 11 to 20 days, and 21 or more days. So in the results, they had 109 patients who were ultimately referred for biopsies by their fast-track pathway, and 5 of them were excluded because the biopsies were not up to the standards previously mentioned. So median age was typical 72 years, and male to female distribution was approximately 1 to 2, with a median specimen length of around 20 millimeters. So out of the 104 patients, 57 were ultimately diagnosed and treated as GCA, and out of these 57, out of these 57, 27 had positive biopsies, and that gave us a sensitivity of 47% with 100% specificity. So looking at the biopsy length, if it was less than 15 millimeters, then biopsy was 14% sensitive, compared to 15 millimeters or more was 52% sensitive, and the difference, as you can see, is very tremendous. So duration of steroids of less than 10 days gave us a biopsy that was 60% sensitive, and over 21 days of steroids had 0% sensitivity, and in between was around 40%. So in patients who had inconclusive or negative ultrasound, the biopsy was sensitive in 38%, and in those especially with inconclusive ultrasound results, 6 of them had inconclusive ultrasound, 4 out of the 6 had positive biopsies. So in conclusion, temporal artery biopsy remains a useful option for diagnosis, especially in patients who had suggestive clinical scenario, but rather negative or inconclusive ultrasound. And as you might know, the ultrasound is sometimes technically difficult as well as operator dependent, so you don't want to miss patients with the typical clinical scenario. The size of the biopsy significantly affected the sensitivity of the ultrasound, and duration of steroids affected the sensitivity of the biopsies significantly as well. So next was an interesting poster about the cancer risk in giant cell arteritis. So in the previous studies, we knew that cardiovascular disease was a leading cause of death in patients with GCA, and previous studies reported no association with malignancies. However, few other studies uh, contradicted that finding and reported positive associations with all types of malignancies, from solid organs to hematologic and lymphomas. So this was a large retrospective cohort that included all incident cases of GCA from 2002 till 2017, and they compared these patients with age and sex matched controls with a ratio of 5:1, and they followed them till either first malignancy was diagnosed, or they've died, or the end of study was reached in September 2018. So they've gathered over 7,200 patients with GCA, and they compared them to over 32,900 controls. And if you look at the characteristics, you see that patients and controls had a similar distribution of age, gender, and socioeconomic status, but patients with GCA were more frequently smokers, obese, and died more often. So looking at the risk of malignancies, you see that the hazard ratio signify that there's a slight increased risk in the solid malignancies, with 12% increased over controls, but the hematologic lymphomas and myelomas were significantly increased over the controls, and almost double that of the controls actually. If you look at the survival graph, you see the dotted line representing the patients with GCA, and more patients with GCA starting to fall for hematologic malignancies compared to controls over years in time, and the separation between the two was significant. If you look at solid organ malignancies, again you see significant separations, but to a much lesser extent to that seen in hematologic malignancies. So independent risk factors were identified, including male, gender, elderly, smokers, and obese. So in conclusion, solid and hematologic malignancies were more common in patients with GCA, and this is perhaps the largest cohorts we saw in patients with GCA and risk of malignancies. Male, gender, elderly, and smokers were at particularly higher risk for developing so. Now, next, I want to rehearse or represent the live lecture that was about the management of Bahjat disease, presented initially by Dr. Hatimi in this year's EULAR. So first, she talked about the management of skin mucosa and musculoskeletal involvement. And as you know, the management of ulcerations in Bahjat starts from the topical, then to steroids and colchicine if they were still frequent or significant, and if there's refractory, then you can go to a Premilast. An interesting slide I found was separating superficial thrombophlebitis from erythema nodosa. And as you can look clinically, they might look quite identical or look the same, but on ultrasound and biopsies, you can see mural or intramural thrombosis with thrombophlebitis compared to panniculitis you see on biopsies. And the significance of that is that thrombophlebitis can sometimes precede a more significant thrombosis, and therefore some experts would prefer to start azathioprine in that case. Next is the management of eye disease, and as you know, we start with steroids and then immune suppression, whether conventional or biologic, and in biologics you have TNF inhibitors and interferon. But interestingly, if you have a patient with recurrent or refractory posterior or panuveitis, then there is some positive anecdotal evidence about the use of tocilizumab or IL-1 blockade, and you can use adjunctive intravitreal steroids. Now, interestingly suggested was a treatment target for uveitis, which was the lack of capillary leakage on fluorescein angiography, and this was based on a study that found the more leaks you have, the more likely the patients will relapse after treatment. Sorry. Okay, so how do we stop TNF inhibitors after treating uveitis? So the author suggested that a minimum of 2 years from the last attack was required with no capillary leaks on fluorescein angiography, and you need to do it in a downstep or downgrade fashion where you stop biologics and start conventional immune suppression, or if the patient is already on them, you continue them, and then you taper the biologic gradually with close eye examination. Next is the interesting venous thrombosis in Behçet's disease, and the immune suppression, as you know, is the mainstay of treatment. To anticoagulate or not is still very contradictory in patients with Behçet's. And however, what is mandatory is that you screen for arterial aneurysms if you decide to anticoagulate, and you continue to monitor for occurrence since they might newly pop up during their the therapy. So interestingly, recanalization was suggested to become a treatment target or be a treatment target for patients with venous thrombosis and Behçet's disease on immune suppression. Of course, if you have more serious immune suppression, then you opt to go for the more serious or immune suppression, including cyclophosphamide and steroid pulses, followed by maintenance treatment and TNF inhibitors if it is refractory or recurrent. So arterial manifestations remain a main cause of mortality in patients with Behçet's, and the treatment for which is heavy immune suppressions, including cyclophosphamide and steroid pulses, followed by maintenance or biologic therapy if the patient is refractory. And if you ought to do an intervention or a surgical procedure, then you should use immune suppression prior to that to prevent deep tissue pathology phenomena and complications. And synthetic grafts are said to survive longer than biografts and therefore preferred in patients with Behçet's. Next is the CNS manifestations. Treatment remains steroids and immune suppression, but interestingly, the duration of steroid pulses was presented to be quite longer than the one we used to, of up to 7 to 10 pulses of steroids. Now, and the topic of cerebral venous thrombosis, immune suppression starts with steroids, then goes to other conventional immune suppression, but anticoagulation again is debatable. But if the patient has got significant thrombosis affecting or threatening to affect the optic nerve, then you might opt to do some interventions, including optic nerve fenestration or shunting to save the vision. GI manifestations are treated in a fashion similar to Crohn's disease, starting from 5-ASA, going to azathioprine, and then biologic therapies. And fecal calprotectin can sometimes help you in follow-up if the patient is still having activity of gut Behçet's. Now I want to move to the again live presentation about the management of large vessel vasculitis, and in there the presented was interesting targeted therapies for large vessel vasculitis, and starting with abatacept for giant cell. As you know, abatacept blocks the T cell co-stimulation signal and therefore blocks T cell functions, and this was studied in small phase 2 double-blind RCTs where they had patients receiving abatacept had better relapse-free survival or sustaining remission at 12 months compared to placebo, but the sample size was quite small and larger trials were needed before a conclusion can be drawn. Interleukin-6 is an important cytokine in the pathogenesis of large vessel vasculitis, in particular GCA, and blocking IL-6 can block multiple things in the pathogenesis, and therefore tocilizumab was very successful in inducing and maintaining remission in patients with giant cell arteritis, and therefore it was approved for use in that condition. To be answered question in the tocilizumab therapy was how long should we treat the patients, and if we treat the patients with tocilizumab, how reliable are ESR and CRPs during the therapy? As you know, they might normalize because of the direct block of IL-6 rather than the remission of the disease. And if we see a patient with normal inflammatory markers, are we treating or masking the disease is a very interesting question. Now, the future holds a few interesting therapies blocking GM-CSF and other cytokines like IL-12, 23, and IL-1 inhibition. And more interesting is blocking multiple cytokines and the JAK-STAT pathway, and studies ongoing for the efficacy and safety of the JAK inhibitors in large vessel vasculitis, in particular giant cell arteritis. Next is the Takayasu arthritis, and this was a very small RCT about tocilizumab versus placebo. It showed tocilizumab had better relapse-free survival compared to placebo in patients with Takayasu. And they've done open label extension of that study, they found that more patients with Takayasu could lower their steroids further and had better quality of life compared to placebo. But unfortunately, evidence is still scanty, and we have some positive reports of use of tofacitinib, ustekinumab, and rituximab in Takayasu, and hopefully the future would bring to us a lot more useful options for this group of patients. So I would like to conclude my presentation by concluding that patients with GCA might have an elevated cancer risk, and we should be alerted to that. Optimization of tocilizumab therapy might be an effective way of reducing the cost of treatment. Isolated aortitis patients can have higher risk of vascular complications, and bigger biopsies in GCA can aid in the diagnosis or improve the sensitivity. Screening and continuing to monitor for arterial aneurysms in patients with Behçets that are undergoing anticoagulation is an important thing, and more targeted therapies are hopefully joining us for the treatment of large vessel vasculitis. And thank you very much.
Okay, thank you very much, Dr. Mufaddal. Excellent review. Of time, we will move directly to our next speaker, Dr. Khawla Al-Ghanem. Dr. Khawla is a consultant rheumatologist in King Fahd Military Medical Complex in Dammam in the Eastern Province in Saudi Arabia. She is a clinical and research fellow in general rheumatology and systemic lupus erythematosus from University of Toronto Rheumatology Training Program. In Canada, she's board certified at the Saudi Internal Medicine Residency Program, and she's board member of the Saudi Society for Rheumatology. So please, Dr. Khawla, the mic's with you.
I would like first to thank Dr. Hanan Al-Rayes and my colleague, Dr. Fahid Da'nizi, for this organization. And on top of that, Pfizer company, Dr. Khalid, for this excellent organization. And of course, the company for organizing my presentation. So my topic for tonight is ANCA-associated small vessel vasculitis. It's a very hot subject and challenging topic at the same time. As you know, ANCA-associated vasculitis is a serious and often life-threatening disease. And usually it's linked to two types of antibodies, PR3 and MPO ANCA. So before I go to the studies that were presented in the EULAR 2020, I would like to take you through this beautiful algorithm. This is from EULAR recommendation 2016. And what they told us in this recommendation that we have like three phases in management of a new ANCA-associated vasculitis. The first phase is induction phase, and the second phase maintenance, and the third phase is follow-up and titration the medication. So I will try to tell you what studies came after 2016 until 2019. Then I will go to the studies that were presented in 2020 to conclude from all these studies what we can take from all this. So as we know, if we have patient with ANCA-associated vasculitis without organ life-threatening disease, we can induce our patient with either methotrexate or Silsipt along with the glucocorticoid. And if we have a patient with life-threatening disease, the recommendation is from EULAR, we have to induce our patient with either cyclophosphamide or rituximab along with high-dose glucocorticoid. However, there was a new study was published in 2019, MICES study. They did compare the role of Silsibt with cyclophosphamide, and the result was really beautiful. And the Silsibt was not inferior to cyclophosphamide, especially for patients with MPO ANCA associated vasculitis. However, there was higher relapse rate, like double of the rate in patients with PR3 ANCA-associated vasculitis. So from this study, we can conclude that we can use Silsibt as alternative for cyclophosphamide or rituximab as induction therapy, especially for patients with MPO ANCA-associated vasculitis. Another thing, from this recommendation, EULAR recommendation in 2016 that advise us to use plasma exchange in patients with rapidly progressive renal failure or pulmonary hemorrhage. However, the rule of plasma exchange was revisited recently in the recent study which was published in a New England Journal of Medicine in February 2020, BIXIVAS trial, and the result was against this recommendation. And the conclusion from this study was, among patients with severe ANCA-associated vasculitis, the use of plasma exchange didn't reduce the incidence of death or end-stage kidney disease. And another beautiful finding from this study, a reduced dose regimen of a glucocorticoid was non-inferior to a standard dose regimen with respect to death or end-stage kidney disease. And what I meant by reduced dose regimen, almost 60% less than the standard dose when they compare it as a cumulative dose. So this is second beautiful finding from this studies that we can use reduced dose regimen of a glucocorticoid. Now let's move to the maintenance phase, and I will tell you where we are. So from EULAR recommendation 2016, they did recommend us to use AZA or methotrexate or rituximab during the maintenance phase. However, I will elaborate further about this maintenance phase during my talk, and I will compare it with a new study that was presented in EULAR 2020. And this phase followed by a follow-up phase, which is after usually 2 years. From this stage, we can titrate our patient gradually according to the situation of our patient. And another thing that I would like to mention before I go to the EULAR 2020 studies, as we know, the commonest cause of death in patients with ANCA-associated vasculitis is infection. It's like 9 times the risk of death as compared with control group, and mainly because of the infection. And the commonest cause of infection is our medication, unfortunately. And on top of that is high dose of glucocorticoid. That's why there was a study was published in 2017, and in this study they did compare the role of avacopan, which is complement 5 antagonist receptor. They did compare it to glucocorticoid, and the result was beautiful. It revealed non-inferiority of avacopan, which is complement 5 antagonist, to the steroid. And even the renal function was much better in patients with avacopan group, and even the life of the patient was much better. However, the side effect in terms of hepatic dysfunction and leukopenia was higher in patients with avacopan group. Now let's move to the first study that was presented with regard to this talk. The title for this study was Maintenance Treatment for ANCA-associated vasculitis in Real-World Practice in Europe, Reality of Vasculitis Remission and Relapse and Significant Burden of the Disease. I will jump to the objective for this study. They want to define and to understand further the maintenance phase and when it will begin. And this study was retrospective observational study. They did involve around 500 physicians from nephrology service, rheumatology, and internal medicine from different countries in Europe. And in this study, the physician did complete retrospectively 3 online case reports form for ANCA-associated vasculitis. And the patient has to fulfill the following criteria. The patient has to be initiated an induction remission treatment, either for a new or relapsing disease between 2013 and 2016. And then they did start him on maintenance therapy. And the data were collected at induction, then at 6 months, 12 months, 18 and 36 months. And as you can see here, they did include around 1,500 patients, half of them with MPA and half of them with GPA, with the mean age was around 54. And most of them, they were male, and 44% had severe progressive disease, 56% moderate systemic disease, and almost half of them were incident, and the other half at the time of the relapse. And 30% from these patients, they were induced with rituximab and 70% with cyclophosphamide. The first beautiful finding from this study that these, physicians, they didn't define, the maintenance phase. Most of them, they said that there is no specific criteria for the maintenance phase. So it was like variable definition, but typically it starts around, as you can see from this diagram, between 5 to 6 months after starting remission induction therapy. And unfortunately, the other thing that I would like to highlight from this study is still the major and minor relapses remain a problem in the maintenance phase, unfortunately. And some patients died and some patients got infection, and mainly they got upper or lower respiratory tract infection followed by UTI. So still we are not doing great in maintenance phase. So they did conclude from this study that we are really in need for new therapeutic approaches to improve the clinical outcome in ANCA-associated vasculitis. Now I will move to the second study, which is, to me, it sounds to be a beautiful study, and I learned a lot from this study. Actually, this is the second randomized control trial comparing rituximab with AZA as a maintenance therapy in relapsing ANCA-associated vasculitis. We know that rituximab is an effective remission induction agent in ANCA-associated vasculitis, and it has been shown from different studies superiority to cyclophosphamide, especially in relapsing disease. But it has been clear that maintenance strategy is required, for which now lots of study now they are studying role of too many medication and maintenance phase. So the objective for this study to know what is the best maintenance strategy in ANCA-associated vasculitis, especially in relapsing population following rituximab induction especially, and what is the appropriate dose. And I will show you in the study design what is the dose they did use, and I will compare it with the previous study. The primary endpoint in this study was time to disease relapse reported at 24 months. So this is the study design for this study. So as you can see from this diagram, we have induction phase, remission maintenance phase, and follow-up. And they did follow this patient until 48 weeks, which is longer than the previous study, which is Menretsen trial. If you did remember, this trial was published in New England Journal of Medicine in 2014. In this study, they did induce this patient with high-dose glucocorticoid. Then they did titrate the steroid until week 20. While in Menretsen trial, okay, they did titrate the dose until month 18. So the induction phase, they did use in this trial rituximab at a dose of 375 milligram per meter square, 4 doses, 1 week apart, followed by 1 gram every 4 months until 20 months. While in Menretsen trial, they did induce these patients with cyclophosphamide, followed by rituximab, that's 100 milligrams duration was longer, and they did compare rituximab to a study was 2 milligram per kg per day, and it's fixed dose throughout the maintenance phase. However, in Mendelssohn trial, the dose was 2 milligram per kg per day and to be titrated every 6 months by half milligram. So this study, it's longer, and the dose of rituximab is higher and over shorter period of time, every 4 months. And the result was really beautiful. Again, the rituximab, as you can see, showed the superiority over azathioprine with a hazard ratio of 0.3, which is really beautiful. And the major relapses and minor relapses is lower in rituximab group. So they did conclude from this study that rituximab was superior to AZA for preventing disease relapse in patients with relapsing ANCA-associated vasculitis following reinduction of remission with rituximab. So we induce with rituximab and we follow these patients with rituximab. I think this is really interesting study. Now I will move to the last study in my presentation, which is, I think, sounds really beautiful to me. An increase in serum calprotectin level in ANCA-associated vasculitis patient during maintenance therapy is associated with more relapse and accelerated renal function decline. As we know, calprotectin is a protein produced from macrophages and neutrophil. And we know in patients with ANCA-associated vasculitis, the tissue infiltrates with lots of neutrophil and macrophage. And we know from the previous study, the level of calprotectin at the induction period is high. But the thing that we don't know, what is the place of this biomarker during maintenance therapy? So the objective for this study is to evaluate if serum calprotectin level variation at 6 months compared to inclusion, which is the M0, was associated with increased risk of relapse within 18 months of follow-up in ANCA-associated vasculitis. And the second outcome from this study to determine if calprotectin variation, I'm telling variation because it's not single reading, they compare from the induction to maintenance, what is the difference? If there is significant difference, it means this is really positive. And also to assess if calprotectin correlated with inflammatory parameters like CASR, CRB, and we know that we cannot rely on ESR and CRB in our patients because they are non-specific, and even ANCA level titer is non-specific, and it can be coming with relapse in some patient and in other patient not, so it doesn't follow the relapse in every single patient. So we need really a good biomarker to follow up our patient. So actually, they did include the patient from Mendelssohn trial, and they did take the patient with complete remission. As you can see, the score is 0. And after cyclophosphamide, they induced this patient with cyclophosphamide and the maintenance with rituximab or AZA. And the relapse, they define it if the BFS score more than 0. And they define the renal function decline from NICE 2015 guideline definition. I will take you now through the results. The first thing that you have to keep in your mind that single calprotectin assay didn't identify patients with relapse. However, the calprotectin change, can predict for us a relapse, especially in patients with PR3 ANCA-associated vasculitis with significant p-value 0.49 as we compare it with a whole study group. Another beautiful finding that calprotectin change predict as well a renal function decline in both group, whole study group and in PR3 ANCA-associated vasculitis with significant p-value in both group. So I can conclude from this study, what they said, that calprotectin reflect the subclinical inflammation occurring during remission leading to the relapse, And calprotectin can be an interesting biomarker to predict severe outcome as relapse or significant renal function decline during the remission maintenance treatment of ANCA-associated vasculitis. And these results must be, I think, confirmed, like what they suggest in a future prospective study. So now moving to the take-home messages. Just concentrate with me. I think, after all these studies that I mentioned, I hope I didn't give you a headache. I think EULAR recommendation in 2020, it should be revisited again. And what I think, after all this study from 2016 until 2020, I think like what they mentioned in Bixivas trial, the rule of plasma exchange doesn't improve outcome in ANCA-associated vasculitis. And if we can use now more rapid taper regimen for glucocorticoid to reduce the risk of infection, I think this is really beautiful finding. And we can, I think, try, for like complement 5 antagonist, instead of a steroid. I think really this is a beautiful finding to replace the glucocorticoid, especially in induction, and even we can use it in maintenance therapy to reduce the risk of infection. As we know, the risk of infection is very high in this entity of patient. Another, I think, message that I would like to deliver, if you have a patient with MPO ANCA-associated vasculitis, you can use Silsipt as induction therapy based on my study, which was published last year, 2019. Last message that I would like to deliver, that you can maintain your patient in rituximab, like rituximab trial, 1 gram every 4 months, but from Minritzin 3 trial, which was, as you remember, they did extend this maintenance therapy, and they did give patients rituximab until 36 months, and the result was beautiful. I think we can borrow as well this finding. The more you keep your patient in maintenance, the less relapse you will get, because we know the risk of relapse is really high, and we are really in need for more effective and safer treatment to treat ANCA-associated vasculitis. And thank you very much.
So we can start the question and answers for Dr. Mufaddal right now. I have many questions, Dr. Mufaddal. The first question, when to introduce the apremilast in patient disease, especially if disease is severe?
So based on the evidence we have discussed, it seems that apremilast isn't really the option for patients with severe organ or life-threatening Behçets. Now, it would be an interesting option for patients with oral ulcerations or refractory oral ulcers that were not responsive despite being treated. Now, remember, if you have a patient who is not responding to lines of treatment, at least one systemic therapy, now according to that RCT, then he's a candidate for apremilast therapy. Now, in the full article of the Relief 3 study, they mentioned that they've included patients with anterior uveitis that were controlled. So if you have a patient with quiescent eye who had previous uveitis, you can give him if he has oral ulcerations, frequent or active. But other than that, the evidence is really not so much. Now, in the trial, not a single patient, to my knowledge, not one patient in the apremilast arm developed a severe manifestation. So that is a good safety point. So if you have a patient who has previous major organ or posterior or panuveitis that was treated and in remission, you can consider it for active oral ulcers. But if you have a major manifestations, then we should stick to the other therapies. Hope that answers. Thank you.
Is there any study to compare it with colchicine? Is it superior to colchicine?
Well, not to my knowledge. Now, the studies, the evidence in colchicine is not up to the quality of the evidence that apremilast gave us, because apremilast gave us well-formed RCTs that showed superiority. But in colchicine, the evidence is a much lower quality compared to apremilast. But to my knowledge, no head-to-head comparison between apremilast and colchicine.
And ocular Behçet?
Now, ocular. Come again?
There's a question for you. If there is any efficacy of apirimeris for ocular Behçet disease?
This was not studied. The patients with actually severe uveitis, posterior or pan, were excluded. Now, patients with anterior controlled or past treated and controlled were allowed to enter the study, but patients with active severe uveitis were not part of the studied group or patients.
Okay, there is another question regarding how frequently do we monitor for aneurysm in Behçet disease? Should anticoagulant used?
Yeah, okay, I got you. This is a very interesting question, and the evidence is very, very scanty or almost non-existing. Now, remember what I presented was an expert opinion. Now, that doesn't put us at a level where we have a well-structured evidence and say that we should monitor at this and that time or period. But this is left up to the primary treating rheumatologist to assess what to do and when to repeat it. So it's a very open-ended or unanswered question in terms of evidence.
And what is your recommendation about infliximab infusion in refractory posterior uveitis?
So in refractory posterior uveitis, definitely you can use infliximab infusion or anti-TNF. It's one of the recommended therapies. Now, do you go immediately for infliximab if the patient has got severe eye threatening? Then yes, there is a tendency for people to lean more towards infliximab therapy. But less or more settled eyes, you can go to first conventional immune suppression, then infliximab.
I wish you all that you will do. You did well in the last 2 days or 2 nights of this Best of EULAR webinar. It's my great pleasure actually that you had a fruitful discussion. Still 2 days is not enough to cover all the abstract, all the research, because you know it's a huge issue. We concentrated mainly on the main abstract and main researches. I would like to thank all speakers for their excellent presentation, careful preparation, and all the chairpersons for their great efforts and active discussion. Actually, we have an excellent feedback from the participants, from all of you. So I can conclude that the purpose of Best of EULAR webinar has been completely accomplished. We wish in the coming years to have it, and always we want to improve ourselves. Based on your feedback, we can improve the SSR activity. I would like to pay my deepest respect to all of you for your positive participation in the webinar, and I hope that you have learned through the webinars some update information that help you in your clinical practice. Finally, on behalf of Saudi Society for Rheumatology, I would like to give my deepest thanks to Dr. Fahed Al-Anizi for his great effort while preparing the Best of EULAR webinar. And also special thanks to Synergy Health UK scientist medical company for helping us for collecting the abstract, helping the speaker for preparing their slides. Also special thank for Pfizer Saudi Arabia for their partnership and valuable support of Best of EULAR this year. And also Dr. Khalid Abdul Shakur for his continuous work day and night with us while preparing this activity. While I want, during this closure, I would like to close my remark with the good news to all SSR members that we will sponsor, the Saudi Society will sponsor all those who are interested to attend the American College of Rheumatology conference. So the same thing like what we did for the EULAR. So again, you can register through the Saudi Society website. All SSR members are more than welcome. And the other interested thing that also I'm working and the society working in preparation, and actually I started the preparation of best of SCR. And I wish the best of SCR, whatever we have defect, because we did this EULAR in just very short period. So because of the COVID-19 issue and the government announcement that tomorrow is free, so we did it early because we want to be most of you available with us. So this is the last night before everything will be open. I wish that it will be great. I mean, this opening, and anything you can write it in your evaluation to improve our activity. And finally, thank you, all of you. And just like what I have mentioned, that we have our registry ready. Any one of you from Saudi Arabia, rheumatologist, wish to join the registry, he can contact me and to do the preparation. Thank you again and goodbye. طبعا I wish that we can see you and say goodbye, but alhamdulillah, I'm just talking to the camera, but I wish that you get what I want to say. Thank you all.